Keep your best years ahead. Longevity Roadmap with Dr. Buck Joffrey.
Hey everybody, it is Buck Joffrey here. And first thing you might have noticed is that we've changed the name of the show. The show was previously called Sapio, and we are moving to a different name. We're calling it Longevity Roadmap. And why is that? Well, when I first started this show, the intention was I wanted to do a show about other stuff other than personal finance, because that's what I've been talking about. And I was really trying to just follow my own passions and say, well, what is it that you really want to talk about? And frankly, I wasn't 100% sure. The meaning of sapio is wisdom. And of course, it has to do with being human, Homo sapien. However, we've clearly moved into this space where this show is about longevity and health. And that's really where my passions are right now intellectually. And it's clear to me that sapio doesn't really make a whole lot of sense. In that regard, I felt like what does make sense is, what I'm really all about, which is this longevity roadmap. You may know that I also have a course called Longevity Roadmap as well. You can find that course at longevityroadmap.com. Anyway, speaking of that course, what I wanted to do is you may know that I've got this course, and it is an online course, several hours of videos, and also I'm doing for a period of time. Anybody who signs up for that, I'm doing one-on-one coaching. It's a great opportunity, frankly, if you were interested in this kind of world. And I have actually really had fun. I've had some people come through that I think are in great health, but they've got just one or two things that I really think that we can make a big difference from in terms of my own background. And of course, my own background, not to congratulate myself too much, but I don't think there's really anybody who's got better medical training than me, having come from the institutions that I've been trained at. And I'm good at this stuff. So it's been fun to be able to take what is intellectually very interesting to me and apply it to people's problems. And so in that spirit, what I really wanted to talk today about, and with the permission of one of my coaching clients, talk about the situation that he's in as a case study to bring up some things that I think are really important. So without further ado, I'm going to talk about our patient who's a 70-year-old guy, and he's actually really, really healthy. He is remarkably healthy. In fact, one of the things that I noticed on just about everybody is that, almost nobody's metabolic health is ideal, right? But this gentleman, 70 years old, is a hemoglobin A1C of 5.2, which, that's the target. I mean, he's not taking metformin. He's not taking any blood sugar stuff like that. But his hemoglobin A1C, and again, what is that? That is a marker of sort of your long-term blood glucose over the course of several months, is targeted at 5.2, which is what I suggest is a optimal number. That is well below, what is considered problematic. Bottom line is, though, the point is that he is metabolically extremely healthy. And that's always where we want to start with these conversations, because from the clinical side, everything ultimately revolves around optimizing metabolic health first and then seeing what's left. That's kind of my own philosophy on this. So what was left in his case was the fact that he, despite having optimal metabolic health and a great blood sugar and everything like that, his LDL and his ApoB are elevated. Now, they're not terrible, but they are elevated in his context, which is that he has a known history of coronary artery disease, specifically soft plaque. Now, we've not talked about this in much detail, but what happens with arteries in atherosclerosis and narrowing of these blood vessels in the heart is that, they start out as plaques that are soft. And that's basically an active lesion, if you think about it. And those are the really, really scary plaques. Those are the ones that can rupture and give you a heart attack. If you have soft plaques, you are actively in coronary artery disease mode. Now, that's very different from a hard plaque. A hard plaque is something that's already calcified. And hard plaques are, they may cause narrowing, but they're not really dangerous because they are stable. They are sort of, if you can imagine, healed over, almost like a callus, right? And it's not surprising, therefore, that these are the things that get picked up on calcium scores for your heart. They are evidence of previous coronary artery disease, but they are not talking about active disease the way when you get diagnosed with a soft plaque, which you can get from a CT angiogram with a Clearly study. That's where he found that out. Now, given that his LDL cholesterol is 99, which, if it was traditionally, if he was somebody who doesn't have documented coronary artery disease, we would say, yeah, that's fine. Don't worry about it. Typically want that on around 100. But his is, again, it's 99. Now, he has known coronary artery disease. So even the traditional rule of thumb there is to suppress that below 70, maybe even below 55 milligrams per deciliter. That's not the case for him right now. ApoB, which we, of course, talk about as a much better indicator for atherosclerotic lipids, is 85. Again, not horrible if he didn't have soft plaque already. As you may know, we target an optimal number of 60 or less in my book of milligrams per deciliter of ApoB. Now, what's the difference? As a review, LDL cholesterol tells you the total amount of cholesterol, which is fine, right? ApoB is important because it tells you actually the number of atherogenic particles. So it includes LDL cholesterol, but it also includes other things like IDL and VLDL and triglycerides. And ApoB gives you the number of particles that are problematic, which is much more relevant to the development of atherosclerosis than LDL. So that's why we talk about ApoB. And again, my target for that, even just for prevention and for myself, is 60 or less milligrams per deciliter. In his case, of course, again, it is 85, and that is not a terrible number. It's really not. Given that you have soft plaque, my warning bells go off, and I'm like, you got to get down. You got to push this. You have to do something about this. Now, what has been done so far is he was tried on a statin. He didn't tolerate it. He had myalgias, which you hear about that often. And so what his physician did was to put him on red yeast rice. Okay. Now, obviously, red yeast rice is not doing the job. But what is red yeast rice anyway? I mean, it's basically using this. Candidly, this is what drives me a little bit crazy, because red yeast rice, the active ingredient that lowers cholesterol in red yeast rice, is identical to the active chemical that works in a statin known as lovastatin. So does somehow giving red yeast, the form of lovastatin in red yeast rice, does that make it better? Does it make it healthier? No, absolutely not. It does not. And so I have to tell you that I am irritated a little bit about the voodoo here. This particular client tolerated this much better than the statins before, which may indicate one of two things. One, he tolerates lovastatin just fine, or B, red yeast rice, one of the big things is you just don't get very much of the drug. And in his case, he needs more of something to lower these lipids. Why is his physician not gone to more aggressive intervention? And the answer is apparently that he was told that, well, his inflammation status, meaning his systemic inflammation, which we measure often with high sensitivity CRP, is low. It's 0.6 milligrams per liter. We like to keep that below 1, and he's doing great. And again, that's another indicator of his really excellent metabolic health. However, here's the thing, right? He has got soft plaque. So he has soft plaque. His lipids are higher than they need to be. They're atherogenic, and he's got low inflammation. So here's the issue. Why wouldn't you treat him more aggressively? And we've talked about other medications outside of statins, specifically ones that I am on. Even though I don't have coronary artery disease, I artificially lower my cholesterol with something called a PCSK9 inhibitor, which is a very, very powerful medication that's hard to get, by the way, unless you don't tolerate statins. And guess what? This particular client does not tolerate statins. So this should be something that you can get through insurance. But again, the reason his doctor chose not to do it is because his inflammation is not high, and therefore he did not feel like he was at a big risk for this. One other thing before we move on, a little bit of note, and we'll come back to this, is interestingly, his ApoE status, which we'll talk about again in a minute, is E2, E4, which relates to his risk for Alzheimer's disease. And we'll get back to that in a second. But let's go back to the lipid issues here. The thing that I want to try to impress upon you here is that the data is pretty clear, right? Now, listen, inflammation plays a big role in coronary artery disease. It does. There's no doubt about it. In fact, you see some people with this extremely high cholesterol levels, and they don't develop coronary artery disease, in part because they don't have any inflammation. All right. But that doesn't mean that's always the case. Obviously, it doesn't, because this is a patient who does have elevated lipids and who does not have significant systemic inflammation. So the moral of the story is a low high sensitivity CRP does not equate to low risk when there are atherogenic lipoproteins that are still elevated. And the presence in this person of a soft plaque confirms ongoing lipid-driven atherogenesis. In other words, you don't need to guess on this, folks. You say, oh, I'm not going to do anything about this because, hey, you don't have inflammation, so you're not going to have a problem with developing coronary artery disease. Well, that's completely baloney. The guy already is developing coronary artery disease. So why in the world would you not treat him more aggressively? By the way, we were not unable to figure out if he had a lipoprotein little a elevation or not. That was not on his current labs that I was able to see. But of course, lipoprotein little a is is another genetic variant. When it's elevated, it also puts you at an increased risk of coronary artery disease. But I'm not sure if he had that or not. Well, hopefully we'll follow up on that and see if it is an issue. But just to back up the evidence again for aggressive lipid management, okay? Again, we talk about ApoB, and what it does is it reflects the total burden of atherogenic particles, right? We talked about the difference between LDL just tells you how much cholesterol. Well, this is telling you how many particles. So you got LDL, VLDL, lipoprotein little a, right? There are these very powerful studies called Mendelian randomization studies, which look it up, but basically they're extremely powerful and they're hard to really argue with, but they conclusively show that ApoB causally drives coronary artery disease, even independent of inflammatory markers like CRP. Specifically, if you're interested, look at the Fourier and Odyssey trials. And what you see there is aggressive LDL and ApoB lowering significantly reduced cardiovascular events in coronary artery patients, even with low inflammation. Again, even with low inflammation. Guideline targets here: LDL less than 55, ApoB less than 60 for patients with established coronary artery disease. So what would I do? Well, I'd get rid of that red yeast rice and I'd start a PCSK9 inhibitor like Repatha, which is extremely powerful, has been shown to achieve up to 50 to 70% reductions in LDL cholesterol and ApoB. I would also probably add some ezetimibe. Ezetimibe, as you may recall, it basically decreases the absorption of any kind of cholesterol that you are getting through your gut, that you're absorbing through your gut. Most people don't absorb very much. Most people, I would 70% are primarily what you call, I don't the technical term for it, but people who make most of the cholesterol in their blood. And that's where statins work well. That's where PCSK9 inhibitors work. Ezetimibe is for, absorption of cholesterol. So I would add that too. Why not? Because there really is no reason to be conservative here in these drugs that are very safe. I mean, you don't tolerate a statin. I get it. I'm not even on a statin. I'm on PCSK9 inhibitors and ezetimibe. Now, the outcome goals here are simple. There's plenty of evidence to show that when you get these cholesterol numbers that low, they can stabilize and often regress soft plaque and reduce the likelihood, again, of plaque rupture and ultimately of cardiac death. I mean, it's a pretty simple thing to me, in my opinion. Now, the other thing that I want to point out is that, again, this gentleman was a great guy, by the way. He also is interesting because he had this history of dementia he's concerned about in his family. And he has ApoE2, ApoE4 alleles. So let's talk a little bit about that. So you get ApoE. There's different types of genes you can get here, right? You can either get an ApoE3 gene, which is like sort of the normal level for your normal risk for Alzheimer's disease. You can have ApoE2, which decreases the risk of Alzheimer's disease, or you can have ApoE4, which increases the risk of Alzheimer's disease. Now, you get two of these genes per person because one's coming from your mom, one's coming from your dad. And often, so the wild type is ApoE3E3, which is what I have. It's just normal risk, right? Now, what happens, though, if you get somebody with an ApoE2, which is lower risk, and the other gene is an ApoE4, which is higher risk? Well, as it turns out, there is a mild elevation in risk associated with an ApoE2, E4 carrier. So, not a huge amount of risk compared to being an ApoE3, E4, but higher than an E3, E3. So, I bring that up now also because we know that high ApoB and LDL cholesterol levels contribute to neurovascular damage, and it's thought to contribute to amyloid deposition, compounding the risk for Alzheimer's disease. So yet another reason to be aggressive about those lipids. Other evidence out there, we know that ApoB impairs cerebral perfusion and promotes amyloid accumulation. We know that lower ApoB in contrast, reduces neurovascular damage and slows cognitive decline. High LDL cholesterol is also associated with faster cognitive decline and greater amyloid burden. And statins and PCSK9 inhibitors have demonstrated neuroprotective effects in ApoE4 carriers. So again, why would you not treat this person with a PCSK9 inhibitor is beyond me. I don't understand it, but that's what I would do. Now, we could go on and talk more about what you would potentially do to lower your risk of Alzheimer's disease, given a mild increased risk with the ApoE2, E4 genotype. But that's going to be the topic of our next coaching meeting. So I will leave it at that. I hope you got something out of this. This is the type of thing that we do in coaching. I feel like it is extremely valuable. Again, if you're interested in this kind of stuff, go to longevityroadmap.com and check out the course. And that's where you arm yourself with all the information and then get some one-on-one coaching with me. That's it for me this week. This is Buck Joffrey for Longevity Roadmap. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe.